Hello and welcome to eviCore Healthcare's educational webinar series. My name is Bill Cornelius and I'm the moderator for today's event. eviCore is a company that empowers the improvement of care by connecting patients, providers, and health plans with intelligent evidence-based solutions to enable better outcomes. If you would like to learn more about eviCore, please reach out to sales@evicore.com for more information. Throughout 2021, eviCore will host free educational webinars that include guest speakers, as well as eviCore subject matter experts, to discuss today's most pressing healthcare topics. Stay tuned for our future webinars with new topics presented each month. And now it is my privilege to introduce you to our panelists. First, hosting our event today, we have Krista Gassler, Senior Director of Affordability at eviCore. She is joined by a distinguished panel of eviCore's own medical directors, Dr. Robert Westergen, Chief of Musculoskeletal Programs, Dr. Sheldon Shiner, Senior Medical Director of Clinical Lead of the Gastroenterology Program, and Dr. Norm Scarborough, Chief of Radiology Services. Together, they will discuss the respective cost and quality components of various sites of care and what eviCore Healthcare is doing to help physicians and health plan members find the lower cost setting that is clinically appropriate for them. Before we begin, just a quick reminder to please submit your questions using the question feature in WebEx. This presentation will be recorded and will be available on demand on the Insights page at evicore.com. Krista, I'll turn it over to you now.
Thanks, Bill. Hello, everyone, and welcome to our Insights webinar series from eviCore. As Bill just mentioned, today we're going to be discussing site of care and its impact on cost and quality in healthcare. I'm joined today by Drs. Westergen, Shiner, and Scarborough. Welcome. Thanks for joining me.
Thank you.
All right. As we all well know, with the ever-present increase in costs, the healthcare industry is always looking for ways to achieve more efficient and more affordable care while not compromising patient care. One key driver of medical expenses can be found in the cost variance between different sites of care. Here's some quick stats to help put the site expense difference into perspective. CMS recently reported that savings generated from 2011 to 2018 from ASC usage was $28.7 billion. Projected total Medicare savings for that same usage is estimated to be $73.4 billion in 2019 to 2028. And a study of commercial claims from 2016 showed that healthcare costs are reduced by more than $38 billion per year due to the availability and use of ambulatory surgery centers. And more importantly, about $5 billion of that cost accrues to the patient through lower deductibles and coinsurance payments. So healthcare delivery offers many types of options about where care can be done, but there can be unnecessary costs when a higher acuity setting isn't always required. But what does site of care and management of that really mean? Let's start today's discussion with defining the term and why it's an important aspect of the healthcare delivery process. So Dr. Scarborough, let's talk for a second about high-tech radiology first. What are the different care delivery options that physicians can use when ordering their diagnostic radiology studies?
Thank you, Krista. It's very nice to be speaking with everybody today. Regarding radiology facilities, there are two major categories. The first of these is hospital-based outpatient departments, also known with the acronym HOPDs. Those are facilities that are either within a hospital physically or they're associated with a hospital. The other category is freestanding imaging centers, and these are facilities that obviously are independent from the hospital systems. They're generally much less expensive than utilization of imaging in the hospital. And they also have very high quality as well in general.
Great. Dr. Westergen, can you talk to us about the different sites of care used to deliver musculoskeletal procedures, and what are some example procedures that are appropriate in these different settings?
Certainly. Hello, everyone, and thank you for attending. There's a variety of different settings where musculoskeletal procedures can be safely performed. That includes those that Dr. Scarborough mentioned, hospital inpatient, hospital outpatient departments, ambulatory surgery centers, but there's also operatories for musculoskeletal procedures where carpal tunnel surgeries could also be done in an office setting with some higher levels of monitoring and oversight, but also in the office exam room themselves. So there's a significant number of these locations where musculoskeletal procedures can be safely performed, from higher acuity to lower acuity, like I just mentioned. The highest acuity would be the hospital inpatient in most cases, and the lowest acuity would be actually in the examination room, face to face with the patient. Procedures that can be safely done in ambulatory surgery centers are many. That's expanded over the last several years. Primarily, it used to be arthroscopic surgeries of the shoulder, hip, and knee, arthroscopic surgeries of the wrist, elbow, and other body areas. And that's been expanded lately to include total joint replacements in the ambulatory surgery center location. In the office, interventional pain procedures can be done safely if the proceduralist has CT or fluoroscopy available in the office setting. So it's not always necessary to go to an ambulatory surgery center for those interventional pain procedures that require image guidance.
Great. Dr. Steiner, kind of similarly, can you tell us how you see different sites of care used in the gastroenterology space?
So thank you and welcome everybody. In gastroenterology, it's very similar to MSK. So many procedures can be performed in any of those venues for various reasons, an HOPD, an ambulatory surgery center, and many physicians in certain areas of the country where there are not many ambulatory surgery centers built actually do them in the office in facilities that are built quite similar to the ambulatory surgery center. So with respect to endoscopy, really the large majority of procedures, meaning upper endoscopy and colonoscopy, can be performed very safely at an ambulatory surgery center or the properly constructed doctor's office. The hospital may be needed for a complex case, and those criteria are very similar to what we would see in musculoskeletal, mostly cardiopulmonary. So if there are substantial comorbidities and that increases the likelihood of admission, the HOPD would be the preferable place. The thing is that most patients are at average risk, and average risk can have their procedure at the ambulatory surgery center, and that would include most of the colonoscopy screenings, endoscopies for heartburn, removal of polyps, and so forth. And that really brings up another important issue with respect to ASCs, is that they tend to be very focused on the procedures that they commonly perform. So if there are, of course, in the country, many endoscopy-focused ASCs, and here they've generally honed in on how to get those procedures performed accurately, safely, and quickly. And that tight focus allows them to have the appropriate equipment that they would use in very easy reach. Staff is specifically trained for the unique problems that they may face, and doctors have their particular preferences for equipment and so forth. And there's a very rapid turnaround time. And physicians at an ASC generally have more control of their work environment.
Great. Thanks for all those definitions. That's very helpful. While we're talking about different sites of care, Dr. Scarborough, can you talk to us a little bit about some of the feedback patients have had on using the alternative freestanding clinics for their radiology services?
Yes, Krista, I'd be very happy to do so. As it turns out, there was a fascinating survey that was done a few years ago asking patients what were the types of issues that were the most important factors for them when choosing an outpatient imaging provider. As it turns out, the two leading areas that they were most looked at most favorably were low out-of-pocket cost, not surprising, and convenience. However, this survey also looked at what patients don't like about the imaging experience. And it was really very interesting to note that they noted that long wait times, that was the number one, or excuse me, the leading issue that they didn't care for. That was not only in long wait times for scheduling an appointment, but also long wait times once they got to the facility. And so I think that's very telling. It's also interesting to note that freestanding imaging centers are very well positioned to address these patient preferences. Generally, these facilities can price their imaging scans more competitively. Due to their lower acuity risk than you would see in a hospital, so they can actually run on a leaner budget. And I can attest to that, being the previous operator of imaging centers. So they run on a leaner budget than the hospital outpatient departments. Also, freestanding imaging centers have a greater flexibility to adjust time slots and schedule more patients, since they really don't have to accommodate inpatients or urgent cases. I can also speak to that because it was not uncommon for my front desk folks to ask me, Dr. So-and-so is calling, wanting to get a patient in this afternoon. Can we do that? My answer was always universally yes. We could always get them in. And so after a while, the folks learned that, and they just assumed we would get them in, and we did. So it's extremely so anyway. This is very, very telling. The survey, and I think as I said, it positions the outpatient imaging centers very well to address those wants and concerns.
Yeah, so you kind of lead nicely into our next topic, which is really around cost. We all hear worrying statistics about healthcare costs and their increase, and affordability is frequently a key concern as well, as we discussed, for patients. In fact, a Gallup poll from 2017 showed that healthcare costs were the most important financial problem people are concerned about, higher even than low wages. And it's important for us all to remember that so many Americans are in high deductible plans. In fact, in 2019, it was around 58% of Americans that were bearing that higher deductible cost. So getting into that a little, Dr. Shiner, we've talked about the ASC setting from a care perspective, but can you give us a little perspective on the potential savings from using the ambulatory setting?
Sure. The first thing to recognize is that currently about 48% of common procedures that can be performed in an ASC are being performed at an ASC, which leaves more than half still in an HOPD. And as you referenced with respect to Medicare and globally, that transition of the 48% saves about $38 billion. And the potential migration of the other cases from an HOPD to an ASC results in another $38 billion that might better be spent in some other fashion, redirecting healthcare dollars so that it's more effective. And we always have to remember, as you mentioned, that usually 20% or more, especially those with high deductibles of those billions of dollars, are costs that are borne by patients. And if we take a specific example, which I think typifies it and can be expanded, let's take a look at colonoscopy. If we go to Texas, the average cost of a colonoscopy performed at an HOPD is $2,700. The same procedure performed at an ASC is around $1,100. Gastroenterologists often schedule 8 to 10 colonoscopies in a single day. Very often the schedules run every half hour or so. So if a colonoscopist does 10 on a particular day, if those were performed at an HOPD, And that one physician on that one day alone has cost insurers and patients an additional $16,000. For people with those 20% copays, assuming they've met those deductibles, that's an additional $3,200 directly attributable to the patient cost that otherwise would not need to be spent. And that's just one day in one place. If we multiply that nationwide, you then get a sense of the cost of the problem and why so many billions of dollars are involved.
Wow, thanks. That certainly paints a great picture of what that site difference can do for affordability. So Dr. Westergen, we know that for musculoskeletal procedures, there's also that variety of settings. So talk to us a little bit about the savings, not only from using the ASC, but also outpatient admission instead of inpatient.
Certainly. As I mentioned earlier, hip and knee replacement surgeries and even shoulder replacement surgeries can be performed safely in the outpatient setting, meaning an ambulatory surgery center. As Dr. Scheinert and others have shared already, that as a surgeon myself, I would prefer to go to a facility that's focused on the procedures that I perform. That makes it better for patients. It makes it better for the surgeon, and the outcomes are favorable in an ASC as they are in other sites of care. So hip and knee replacement cost can be 139 to 159% more when done as inpatient, hospital outpatient versus ambulatory surgery center. And knee arthroscopy, which is a much higher volume procedure than hip or knee replacement, it can be more than twice more expensive inpatient, hospital outpatient than an ambulatory surgery center. It's more than just about the savings like we've been presenting. It's about patient safety, patient convenience, and on top of that, the affordability issue is important to call out. But again, these procedures can be done very well, especially major hip and knee replacement surgeries in an ambulatory surgery center.
Great, thanks. Dr. Scarborough, radiology studies are frequently ordered by physicians to determine what downstream care would be best for a patient. But when done in a hospital setting, there's still that price difference. So talk to us a little bit about what you see in your clinical area.
Yes, that's a very good point, Krista. As a matter of fact, computed tomography or CT scans, as well as magnetic resonance imaging studies, which are also known as MRIs, these can cost, depending on the procedure, can cost anywhere from 170 to almost 250% more in a hospital outpatient department setting when compared with that of a freestanding imaging center. So it's a very significant cost associated with those using those hospital facilities.
All right. Thank you. I appreciate each of you kind of going over those differences. So with each of these potential changes in site, we've just heard about the cost difference. The savings can really add up. Again, not just for health plans, but also for individual patients. So let's talk for a minute now about how health plans can leverage eviCore's utilization management process to also manage these site and cost differentials. So here at eviCore, I'll kind of introduce the goal of our site of care product is to help physicians and members find the most economical and clinically effective place to deliver care. One of eviCore's initial areas of focus on site of care affordability was our Smart Choice program. We've been involved in helping members also get to lower cost settings since 2005. And that program still works now to offer a great patient-centric model that's even more valuable in today's consumer-driven healthcare market. Our affordability strategies have since expanded to include the clinical review of site decisions as well, as we've just heard. Site of care optimization is an important tool within eviCore's healthcare's utilization management portfolio of services to help ensure that high-quality, clinically appropriate, and economically optimized sites of care are utilized for services and procedures. So Dr. Scarborough, let's start and kind of talk about high-tech radiology space and what eviCore has done in the affordability and site of care area so far.
Be happy to, Krista. As you noted, eviCore has been engaging members as part of our Smart Choice program with outreach and education since 2005. For this, we've used a concierge approach, helping members with scheduling their imaging procedures and educating them on their various options for having those procedures done. We also offer a clinical management for for site of care now. We administer medical necessity guidelines for site of care as part of our utilization management processes. Our automated system can help providers find lower cost freestanding imaging facilities, or they can attest to why the imaging in a hospital outpatient department may be necessary instead. So we're able to address those issues.
Great. Dr. Westergen, can you give us some information about what eviCore can do to help support affordability for MSK procedures?
Certainly. On the musculoskeletal programs, we have relationships with clients whereby we use a evidence-based clinical criteria to make medical necessity determinations for inpatient place of service versus outpatient place of service. And that evidence-based criteria is sometimes chosen by our clients. They prefer to use a MCG, or formerly Milliman, or interqual criteria for these determinations for inpatient stay. These criteria include exceptions that would justify an inpatient place of service for those procedures. And again, the client themselves often request that we use MCG or interqual because that's what they're currently using for concurrent bed day management and for other purposes. And as eviCore, we've already executed on both of those, both MCG and interqual for our clients. As an extension of that, as I mentioned, there's a variety of different sites of care that we can use in our musculoskeletal program. We're launching the ability to redirect from a hospital outpatient department to an ambulatory surgery center, again using evidence-based guidelines to determine the medical necessity, with exceptions that are appropriate for the hospital outpatient department place of service, primarily because those hospital outpatient departments are often on the same campus or essentially connected to the hospital. So if a patient requires urgent care or an urgent consultation by another consultant or physician, they're nearby in proximity. And that's important, especially for patients that have that could have some challenges during the procedure. And there are exception reasons, like we mentioned before, that would justify hospital outpatient departments, such as requirement for prolonged general anesthesia. The patient has a history of pulmonary or cardiovascular conditions that are not yet optimized, and there's others that we can share as well. Now, the evidence-based criteria that were developed by eviCore, we took into consideration the criteria from a number of different professional organizations that represent the physicians who are engaged in this care. Those organizations include the ACC, or American College of Cardiology, the American Heart Association, American Academy of Sleep Medicine, New York Heart Association Functional Classification, Canadian Cardiovascular Society, American Academy of Pediatrics, and so on and so on. So that input is taken into serious consideration when we develop our criteria at eviCore, not just for site of care determinations, but also for prior authorizations of the procedures we're delegated to also prior authorize. In addition, we're developing a site-only review program. eviCore does, in the MSK space, does not prior authorize all musculoskeletal procedures. For example, procedures involving the elbow, wrist, hand, ankle, foot, etc. But the site-only review program would allow medical necessity determinations for the site, even though eviCore is not delegated to prior authorize the actual procedure, because most, if not most of these procedures that I mentioned, carpal tunnel syndrome, arthroscopy of small joints, can be performed safely in an ambulatory surgery center and don't require the connection to a hospital outpatient department.
Great. Lots of different options in that area. For Dr. Steiner, I know that site-only review, as Dr. Westergan mentioned, is one component of gastroenterology site management, especially for screening procedures. But tell us a little more about that and what upper GI site management might entail that's different.
Sure. We're set up relatively similar to MSK in that we will have the capacity for both utilization management of particular procedures as well as site-only utilization management. So our program, which is actually in operation now for upper endoscopy, capsule endoscopy, and colonoscopy, non-screening colonoscopy, meaning diagnostic or surveillance colonoscopies. We actually have established guidelines based on the specialty societies' recommendations on utilization management of those particular procedures, so we can determine whether the procedure in and of itself is indicated at the current time or not. We have a group of dedicated gastroenterologists who do those cases. In addition, we could add site of care to any one of those programs so that if we were doing endoscopy, upper endoscopy, we could make a determination as to the applicability of the procedure or the appropriateness of the procedure itself, and then the appropriateness of the facility itself, whether the HOPD, if that is requested, is the appropriate facility. We do not would not plan on adjudicating whether the ASC is appropriate. It's only when the HOPD would be requested that our guidelines would be used to make a determination. Those guidelines are, as Dr. Westergan explained, are very well vetted and are consistent with the established guidelines from various societies and so forth, and that we would use the same criteria that MSK would use, musculoskeletal, primarily because the decision to have a procedure done at an HOPD is really based on the patient's overall medical status, not the particular, necessarily the procedure that's being done. So as explained, if they've had cardiovascular issues or pulmonary issues, and they're going to be in need of proximity to a hospital, or one might expect that there's a high risk that they may need admission post-procedure, those are the types of procedures where we're going to want to do that at an HOPD, and those would be the reasons to approve that. But again, we should always recognize that the vast majority of procedures, which are average risk, and that's why average is average, those patients can be very safely performed in an ambulatory surgery center. So that's a nutshell of the GI program. Just as a plug, since I have the phone, I'll mention that we also have a colorectal cancer screening program, and that is another aspect for which site of care is appropriate. So, for example, as part of the colorectal cancer screening program, let us say someone has a positive FIT test, that they do a stool test for blood and it ends up being positive. We would then have the capacity to perform site of care redirection, both encouraging the patient through a navigator system to get the colonoscopy, that's number one, and number two, to get it at a place that, at a facility that would be high quality but cost effective.
Great. Yeah, thank you for adding that. That's a really important preventative care offering as well. So thanks to all of you for breaking down those options. We certainly have a lot of different ways we can help support different programs. So one other area we didn't cover today that I want to make sure we mentioned is an offering eviCore has for oncology site of care. So we offer a few different things here, but focus on ensuring timely access to care through a limited duration authorization process. And that allows providers and patients time to educate and shift away from the hospital outpatient to a more cost-effective setting such as in-home or an infusion clinic, whenever medically appropriate. And a study published recently cited that patients treated in a community-based practice instead of a hospital could save as much as $8,000 per treatment. So that's another important area that we want to make sure and call out. So as head of the site of care team, I see how hard eviCore is working to expand this capability and ensure we can support our clients' affordability strategy. eviCore has always helped providers make the right decision. We're just expanding to that review into where the procedure happens. We believe our 16 years of experience and access to referral provider data and analytics can help us create a site of care affordability strategy that best meets our clients' needs, while also helping the industry and, most importantly, patients save money without sacrificing quality. So thank you again for all the insight. We're now going to go into a Q&A session. So our first question, this is for Dr. Westergen. What resources are available to help develop clinical rules around site usage, and what's eviCore's ability to help with that?
Certainly, eviCore can't set clinical policy on behalf of our health plan clients, but we are always eager to partner and collaborate on developing evidence-based guidelines or criteria, not dissimilar to how we currently partner with our clients in developing clinical criteria for the medical necessity of the procedures that were delegated to manage by our clients. And part of that process includes leveraging all of the clinical experts at eviCore. We currently employ more than 350 physicians of every medical and surgical subspecialty who participate in the collaborations in developing criteria or guidelines with our clients. eviCore currently has guidelines that we're using, as we shared earlier, for ambulatory surgery site of care medical necessity determinations. And we also have criteria, as Dr. Scarborough mentioned, for freestanding radiology imaging centers. As I mentioned earlier, if a health plan is already using MCG or Milliman or InterQual for concurrent bed day management, eviCore has already adopted those guidelines to address the site of care determinations based upon the medical necessity criteria within those guidelines. And again, we can implement with our clients leveraging either MCG or InterQual at their preference.
Great. All right, this one's for Dr. Scheinert. How far will customers need to travel for services when site of care is in place?
That's a good question and always a concern. The objective in any of these site of care redirection programs is not for the purpose of having patients travel. No one wants to do that. You want the ambulatory surgery centers to be convenient to the patient. So for example, in New York City, Manhattan, travel may be 2 blocks away, but in Montana, it may be a longer trip, and we have to take that into account. And we would take that into account the following way, that we would be working with our clients to establish what those reasonable travel distances would be. So if you're in Montana and it's 50 miles to an ASC, but the hospital is right across the way, we would not make that patient travel. They would simply go to the hospital because it's too much of an inconvenience. So we would be working with our particular clients to establish that, and it can vary based on, just as we said, the location. Various zip codes, areas which might have different travel limits, but a travel limit would be set, and that would be set for the purpose specifically of limiting patient interference, making it convenient for patients.
Right. Yeah, Dr. Scarborough certainly reminded us about patient convenience earlier, so that's an important factor. So, yeah. And just to remind for our attendees, if you have any questions, you can utilize the Q&A function, and we'll see those come through and answer those as well with time allow. All right, one more question that we've currently got, unless we have some others come in. Will urgent requests require site of care review? Dr. Scarborough, can you answer that one for us?
I'd be happy to. No, the answer is no. This program this redirection program is not designed for urgent request, nor is it designed to be used for inpatients, obviously, or patients who are in the emergency department. So this is purely for non-urgent outpatient imaging.
Great. That's an important clarification. All right, next question. How will the site of care program impact ordering providers? Dr. Schreiner, can you answer that one for us?
Sure. That really depends, and it would depend on how the provider wishes to perform their services. For the most part, since, at least in gastroenterology, a large proportion of gastroenterologists perform their procedures already at an ambulatory surgery center, they're not going to be impacted at all with respect to site of care. So for as long as they continue to do their procedures at the ASC, there's no particular additional administrative burden. The additional the additional burden would occur when a patient, when a request is made for having the procedure performed at a hospital outpatient department. And it would be that case that would come to us for medical review. Whatever the criteria that the client and eviCore would agree would be used to make a determination as to whether the HOPD is appropriate in that setting, and then make a final determination with authorization and so forth. But that's where the additional work would be. It would be only when requesting an HOPD. It would not impact all the procedures that are performed in an ASC. We wouldn't have to touch that at all.
Great. All right. Let's see. Double checking to see. All right. We've got one question that came in. So what are the barriers to shifting from hospital outpatient to ASC, and how are the programs designed to address those barriers? Let's see. Let's see, Dr. Schreiner or Westergen, do you want to talk about the barriers from using the hospital or the ambulatory surgery? We're trying to
sure.
Yeah.
Bob, go ahead. Yeah.
Yeah, from a musculoskeletal perspective, the barriers are behavioral on the surgeon's part. In other words, surgeons will have block booking times both in the inpatient hospital and hospital outpatient departments, and also in ambulatory surgery centers. And if surgeons don't use that block booking, they will often lose the convenience of block booking, and that's doesn't work well for surgeons. We want to be very efficient and not travel in our car from place to place if we don't have to. So one barrier, again, is the provider behaviors that have been embedded after years and years of practice, and the nature of the surgeons themselves want to be very efficient in where these surgery procedures are being performed. So if there is a procedure that can be done in an ASC and they happen to be working in a hospital outpatient department or inpatient facility, just for the sake of convenience, the surgeons would want to do those procedures in the inpatient or hospital outpatient department instead of having to get in the car to travel to the ASC to do that procedure. So that's the first barrier that comes to my mind. And again, it does, as the question states, it is based quite a bit on the convenience and the current practices of the surgeons performing those musculoskeletal procedures. Often patients will ask us to go to an ambulatory surgery center because they had a prior good experience. So that's not really a barrier. That does incentivize the surgeons themselves to select an ASC because that's really what their patients want, and that's what we're in this to do. Unless it's places the patient at inordinate risk for complications, we would often comply with that patient's request to have it in ASC. Dr. Shiner, do you have anything to add?
Yeah, I would just say, for the gastroenterologist, really the barriers would be quite similar. So gastroenterologists, particularly if they might be even employed by the hospital system, are going to, some of those will be incentivized to do their procedures at a hospital. So that's a disincentive to using an ambulatory surgery center. But some doctors, for example, use the hospital because that's where their office is. And so they walk across the street and they would prefer to use the hospital. So that's going to be a barrier. That block booking also pertains to gastroenterology as well. So it really parallels the same types of issues that Dr. Westergaard noted. Particular equipment isn't really, and we should stress that, particular equipment is not a barrier. So, for example, if an endoscopy, if particular stents need to be used, or there's an injection of Botox that's being planned, or whatever it is, and the hospital has that particular type of equipment, that would be an automatic approval because it's only the hospital that has or carries the particular instrument or whatever is needed for the procedure. So those are not barriers. The fact that an ASC may not have the particular equipment, we don't expect you to go there if you don't have the equipment to do the procedure. But most of the time, for the average colonoscopy, the average endoscopy, and so forth, most of those surgery centers have the equipment that's going to be needed for the vast majority of procedures. So that's not really a barrier, but the barriers are very similar for MSK and GI.
Right. And one thing eviCore does partner with our health plan clients on is a lot of provider education and forums leading up to a site of care implementation to make sure that they understand the processes. And, you know, even though behavior patterns may have historically been there, with enough notice and time to get privileges and understanding which patients that would apply to, hopefully that gives providers enough time to kind of adjust some of those processes. And again, we have a lot of referring provider data, and so that's something that we monitor as we go through an implementation and a go live to make sure that health plans and providers understand what works best for their patient mix as well, because that can be more unique. All right, and we do have a quick follow-up question, it looks like, related to Medicare specifically, and I know we talked a little bit about the clinical guidance for when the hospital outpatient should be used. Is that any different for the Medicare population, and is that a different kind of shift maybe? I know, Dr. Westergaard, we do some inpatient to outpatient for Medicare. Do we also do hospital outpatient to ASC, or is that kind of a different population to manage?
The question, I think, has to do with the severity of illness or penetration of those comorbidities in a Medicare population compared to a commercial membership. And the opportunity still does exist in that Medicare population, despite the higher penetration of comorbidities, because if those comorbidities are stable and optimized and well controlled, that does not disqualify them from receiving musculoskeletal procedures in a facility with lower intensity of services available to them. It can still be safely done in that membership. Admittedly, like was asked, the penetration of comorbidities would expect it to be higher in that membership, but again, there's still opportunity to transition those patients safely to a lower level of place of service. So that does not disqualify them.
Great. All right, and I think we have one more, and this is a little bit more about the physician's payment for procedures at different settings. And that's certainly something I know eviCore can consult on, but typically that relationship is between the health plan and the provider. But I don't know, Reinert or Westergen, if there's anything else you would want to add to that question.
Actually, it's an interesting question. I'm sorry, it's an interesting question because in the interventional pain space, eviCore is working toward identifying interventional pain providers who have the ability in their office for the image-guided procedures that require fluoroscopy or CT, and working with our clients to essentially provide them with enhanced payment for the procedure they're doing to help offset the overhead costs associated with the staffing and equipment required for fluoroscopy or in-office CT. So it's a great question. We're pursuing that in partnership with our clients, and that's a good example of incentivizing a lower level of service for interventional pain procedures. The office operatory is another one which could be an opportunity to partner with our clients. There is no specialized place of service code from AMA CPT for an office operatory versus just an office, but it's certainly justified for an office operatory to receive some type of enhanced facility payment or enhanced global payment for doing the procedure in office operatory, because again, the costs are slightly higher, overhead costs for an office operatory, certainly than an ASC. So I think it's a great question, and stay tuned, and I hope we can work with you all in that regard.
Great. Dr. Shiner, anything to add real quick, or?
No. That was a good, complete answer. Only to say that in the context of our gastroenterology program, we do not offer different payment structures for where the procedure is done with respect to the provider. And as you indicated, at least in gastroenterology, that would be between the client and the provider.
Right. All right. Well, great. I believe that's all we have time today. Thank you, Dr. Westergen, Dr. Shiner, and Dr. Scarborough for your time and insights. Also, thank you to all of our participants for joining. We appreciate your time and attention and hope that you found today's webinar valuable. And now, Bill Cornelius will provide some closing remarks.
Thank you, Krista. This concludes the Q&A portion of our webinar. This webinar was recorded and will be available on demand by visiting eviCore.com. Please remember to register for our upcoming webinars. You will receive an email invitation with the opportunity to do so. If you would like to learn more about our capabilities, please reach out to sales@eviCore.com. Thank you again, Krista, and our medical panelists for sharing your expert knowledge with us today. Participants, thank you all for your attendance, and this concludes our webinar. Have a great day.